So this is most likely going to be the least scientific talk. I'm going to try to confuse you with all those kind of lesions which may look like a tumor, and we shouldn't underestimate that. It's of course extremely important that we do not overdiagnose and do not underdiagnose. So that's what I'm going to try to do with you, to go over a couple of cases where it was difficult or it can be difficult, and I have a lot of questions sitting in there. I tried to make it a little bit more interactive, but you don't have to answer it with your answering box. So you heard everything about supra and infratentorial brain tumors, high-end advanced imaging, so everything should be very clear, straightforward and clear. So what do we see over here? We see here a very straightforward case. An axial T2, axial T1 pre and post contrast, and we see a cystic solid tumor within the posterior fossa in a child. What should it be? It is only one diagnosis here one diagnosis, a pilocytic astrocytoma. I suppose everybody agrees. You agree, Tina? Yes. Okay. Now, it's amazing that even when you're looking at a very rare tumor, most of the time, everybody knows what it is. This is a tumor I have seen 2 times in my life, and it's also debatable if it's a real tumor, but every time when I show it to a resident or a fellow or whoever who is interested in neuroradiology, they always immediately know what this could be. We see here an expansile T2 hyperintense lesion, which is respecting the folial pattern and anatomy of the vermis, but also of the cerebellar fissures. It is not really expansile, it's a little bit expansile. It has some ADC hyperintensity. There's no real enhancement, and when I show this, everybody says this is a Lamy Duclos. So even when the lesions are very rare, usually you will immediately make this diagnosis. Now, imaging may be confusing. This is not a tumor, and some of you have seen the next 2 cases, which I'm going to show you because I love both cases very much and I think they're didactic. So this is a head CT. And we did this head CT because of developmental delay, and there was some questionable story about the torch infection. And we see over here rather shallow orbits or sockets. We see something cystic sitting in there. It looks like somewhat deformed orbits or eye globes, and apparently the lenses have been taken out because something else sitting in there, hyperdense. Now, this can be really confusing. But of course, you are not confused, and what I did is just I turned around the CT image of a child who has 2 shunt reservoirs, which you see over here, and these are not the eyes. The eyes are there. So you may be confused only by flipping the image and by linking it some way with the clinical information, or some kind of clinical information. Now, this is my most favorite case, and I'm sorry if you already saw the case before, but I just love it. It's a case which I got from Anna Neidecker, one of our fellows in neuroradiology. And this was a patient who had back pain. That was the story. The patient has an ataxia and a wobbly gait. Now, if you look at the sagittal T2 weight image, this cervical lordosis is kind of threatening, isn't it? You don't want to have this kind of a hyperlordosis. Or if you have it, I would say just run out and go to a hospital and get it some way realigned. Now, you're confused with this case because you are maybe not familiar with the anatomy or the findings or the pathology. Now, this is a penguin. And this was studied at Hopkins by Dr. Neidecker. I have no clue how we knew that this patient had back pain. I think the communication with the penguin will be limited if you look at the size of the supratentorial brain, but there's a big cerebellum, and nevertheless, there's a wobbly gait. So I just want to say imaging may be confusing. Now, what is a tumor and what's a tumor-like lesion? And we are all experts, aren't we? And I didn't want to put a picture over here of an expert because we are all experts. And because we're an expert, we can say, this is so straightforward. I know this is this pilocytic astrocytoma you showed before, a solid nodule and a cyst, and this is an arachnoid cyst. What else? Now, let me make it a little bit more difficult for you. It's not completely honest because I'm showing you 8 cases, 8 different cases, and only T2 weight images. And they all have T2 hyperintense lesions sitting within the, I would say, pons. So there's well-defined, less well-defined, mass-like, multifocal, ill-defined again, mass-like, difficult to define, also somewhat ill-defined. So my question to you would be, how many true neoplasms are shown? Now, if you have to put in an answer, and you don't have to put it this time, I think I will get a rather Gaussian distribution of answer. Would you agree? Anybody would like to say how many tumors? I don't want you to expose yourself because I would fail completely. There's only one tumor. All the others are non-tumors. And because I usually can't remember which one the tumor was, I put the names next to it. This is the stroke. This is an acute disseminated encephalomyelitis. Can be rather mass-like. This is tuberculosis, tuberculomas. This is an Alexander's disease. This is neurofibromatosis type 1 with the well-known UBOs or unidentified bright objects with the two hyperdense lesions. This is a neurodegeneration in a child with Langerhans cell histiocytosis. Hey, we have the brainstem glioma, a real tumor, and acute necrotizing encephalitis. So differentiation may be difficult. So when do we as radiologists call a lesion a tumor? We think it is a tumor. And we always say, yeah, because we see a mass or a focal density on CT or a focal signal alteration on MRI, or we see the structures are being displaced, like here the vertebral artery, or they're surrounded, or there's maybe edema and there's contrast enhancement. Now, what is a tumor like? A tumor like is anything that resembles a tumor but is not a tumor, or as we usually translate in our report, finds compatible with a tumor-like lesion. However, neoplasm cannot be ruled out. Clinical correlation, follow-up imaging, or examination necessary. Or what is this lady saying over here, looking at the skull film of this gentleman, Mr. Johnson? I didn't recognize you with your skin on. There was not enough information to make the diagnosis. There were maybe not enough sequences, not enough clinical information. It's important to correlate the clinical information. So you need, and we all know this, but I also see how often we forget to do this. We have to collect a good degree of good, reliable clinical information which is relevant for the case. And you have to have a good neurological examination. And if a patient comes in over the ED, frequently, or in my institution, I have the impression those patients are being examined by the first-year resident, if you're lucky, maybe even by the medical student. So you do not always have a good neurological examination. And we should be very familiar with all neurological diseases and pathologies which we can expect or encounter in the various age groups, in the various boys or girls. Now, I always find this an impressive case because I'm impressed by my colleague and I would completely fail in this case. Not completely, but I would fail in this case. And I just want to share it with you how important it is to have the good clinical information and to correlate it. This was a 5-year-old boy who had been playing with friends and collided with a much larger child. I suppose that means an obese child. So there was no loss of consciousness, but the patient became lethargic, went to our ED, and there apparently recovered, Glasgow Coma Scale 15. CT was done, and the only previous history which we heard of was there was something about some eye issues. Anybody disagreeing with me there is a skull fracture? This is a skull fracture. Now, the neuroradiologist who read this, and I admire him for seeing it, he saw also something else. Does anybody see what else he saw? So maybe he was already a little bit pushed by the fact of eye issues. I don't know, or he's just a really good radiologist. And he described there was a focal hypodensity dorsally to the fourth ventricle, and he said we should do some follow-up MR imaging. I think I would have missed it, honestly. Now, MR was done. And there is indeed a focal T2 hyperintense, somewhat ill-defined, minimal mass effect, contrast-enhancing lesion sitting over here. Okay, so he was right. And apparently these eye issues helped him a little bit. Now, my question would be now, is this a neurofibromatosis type 1 or 2, tuberous sclerosis, or Bournonville-Pringle, or von Hippel-Lindau? And of course, you're looking at every single piece of information. And if you're answering multiple choice questions, of course, you would know tuberous sclerosis and Bournonville-Pringle are the same, so you can rule that out. And paired answers are usually one of the two is correct, so it must be NF1 or NF2. So look at the optic nerve. It's thickened and elongated. And we had this focal lesion over here. So the final diagnosis was neurofibromatosis type 1. So it's important to study every imaging feature and to use the clinical correlation, the clinical data. Because we know neurofibromatosis, we support the diagnosis, but it is a clinical diagnosis and you have to fulfill 2 or more of the following 7 criteria. And over here, there was an optic glioma, the patient had axillary freckling, the patient had a first-degree relative with NF1, so everything fitted at the end. So you have to be careful not to miss a tumor, not to underdiagnose a tumor. Now, since yesterday, I think I know who reviewed the paper for me once, and there was a paper which I submitted because I did not know what I was seeing, and if I do not know what I'm seeing and somebody teaches me, then I want to share my ignorance or my graveyard of missed findings with other people, and this is a case like that. And yesterday I saw that this is a very well-known finding apparently. I didn't know it. It was difficult to publish it, but it was a case of 2 children with tuberous sclerosis and seizures. And I saw a triangular shape I call the zebra-like contrast enhancement sitting in the cerebellum here, another case over there, and they changed over time in their contrast enhancement. And they had to study the literature, and of course I found out eventually that this was the typical infratentorial appearance of the tuberous sclerosis complex, which you also see in the supratentorial region. I tried to publish in AJNR, it was rejected because the reviewer told me this is so well known. Okay. Now, most people in my institution, the fellows at least, they don't know it. But this means you have to know it to recognize it accurately. And if you don't know, read. Okay, next case. This is a 5-year-old girl, and I have here a T1 weighted image with contrast of the posterior fossa. So if you look at this image, this figure, and you would like to make the diagnosis, is this a giant cell astrocytoma, or a pilocytic astrocytoma, or an hemangioblastoma, or an ATRT, or a meningioma, you will make the diagnosis based upon your knowledge and, of course, based upon your experience. And what is your diagnosis? There's no image. And I know. What is the diagnosis? The diagnosis is you don't need it immediately because you will use your statistics. I know there's no picture. It is most likely pilocytic astrocytoma. What I want to say with this case is take advantage of the statistics to prevent the issue that you maybe make the diagnosis of a tumor when there should be no tumor the other way around. And we heard this before from Tina, which tumors you see in the posterior fossa. And we know the pilocytic astrocytoma is the number 1, followed by a couple of others. And meningioma, schwannomas, metastatic disease are just very rare in children. So don't make the mistake to make the diagnosis of the most infrequent tumor as the number 1 diagnosis. Don't forget this, and it is of course very well known that a rare manifestation of a common disease is much more likely than a common manifestation of a rare disease. Brain tumors are, thanks God, still very rare in children, and infectious diseases are much more frequent in children. We should not forget that. And before we had diffusion-weighted imaging and all the advanced imaging, this was a diagnostic challenge. And I'm unfortunately also somewhat longer in neuroradiology. That means that there was a time we didn't have diffusion-weighted imaging, and my teacher would say, oh, you can easily differentiate those 2 cystic lesions because you look at if there's a peripheral enhancement and the amount of edema, the primary location where you have more enhancement, how thick the rim of enhancement is, and then you can make an estimated guess of is this the GBM? Or is this a GBM, or is an abscess the other way around? Now, if I ask you this, I force you to make an estimated guess, I suppose most of you will make the correct diagnosis. Which one is the abscess? Now, the abscess over here is patient B, has a very thick rim, and a lot of edema around it. Now, nowadays, it's so much easier, and you cannot make the mistake to make the wrong diagnosis in these 2 cases. Now we have advanced imaging, and nevertheless we still use good anatomical imaging. But you can do MR spectroscopy, you can get a digital fingerprint, and especially diffusion-weighted imaging will help you. T2 hyperintense, T1 hyperintense peripheral enhancing lesion over here, and over here. But diffusion-weighted imaging is so different. Here it is ADC hyper, DWI dark. Here it is DWI bright, ADC dark. This is the abscess, restricted diffusion because pus is sitting in here. And here it is DWI hyper, ADC, it is iso, a little bit hypo, and this is a solid tumor, but this was a necrotic tumor. So diffusion rate imaging makes it so much easier. Now, to prevent the situation that you make mistakes is also, and we saw this before, you have to know your imaging characteristics. And this is another case of pilocytic astrocytoma, cystic solid. You have to know the imaging features. And there's so many basic imaging features, we should not forget those. A medulloblastoma, typically in the midline, posterior fossa, typically hyperdense because it is a blue round cell tumor with a high cellular density. The other one is the ependymoma, what is basically the two-space tumor. The ependymoma typically originates from the inferior or posterior, which is the original name, velum medullare, and from there the tumor, which is rather soft, will extend along the space of the ventricular system through the foramen of Magendie or Magendie in the American language, will go around the brainstem and encircle it, can even go into the internal auditory canal. This is the two-space tumor. You just have to know those imaging characteristics. And we saw those tumors with diffuse intrinsic pontine gliomas, and they are bad, we know this, but we also know that typically they will embrace the basilar artery, and it's never good to embrace a shark. It's also not good to embrace your basilar artery. These are typical features of a diffuse intrinsic pontine glioma. Now you have to be familiar with look-alikes. I don't know why everybody is laughing about this case, and I know that Michelle will look at me, and I upgraded my talk. Don't worry. This is a pretty girl. This is a pretty dog. Okay? They have similar kind of hair, but they are not the same. They look a little bit alike. Now, this is a solid cystic tumor. You agree? Posterior fossa. So this should be a pilocytic astrocytoma. But it is not complete. And before I go there, this is just from Michelle. As I once showed this, she said this is not how it should be because you should show also a male person with his dog. There you go. I think the girl is prettier than the guy, by the way. But okay. So if you look at this tumor, something is different. So always study your images carefully. Something does not fit. It looks like a dog, or maybe not, but you recognize something is wrong here. You have to recognize what is wrong here. I'm not going to tell you what it is yet. But look at those vessels. There are too many vessels. And you want to alert the surgeon before he goes in, and he ends up with a big bloody tumor. Now here also, use the clinical information. It's so helpful. And especially, I suppose, there will here be a big contingent of pediatric radiologists. Use also the information from outside the central nervous system. This is another patient, and this patient was a young adolescent who came with recurrent history of headache. Had multiple MRI studies at St. Elsewhere of the head, and they were all read as normal. There was a medical history which was relevant for a cyst adenoma of the epididymis. This is not in the brain. And multiple pancreatic cyst is also not in the brain. So what is your diagnosis? If you read this story, you should already think a little bit about what could this patient suffering from. And we looked at the MR, the outside MR studies, and it was in the time period where still everything was nicely magnified, and this part of the brain was cut off, so we got the CD, we opened it up a little bit, and we saw this T2 hyperintensity sitting over here. And it was seen on basically all the three studies, and it became more and more apparent. Now, what is your most likely diagnosis? Cyst adenomas of the epididymis, pancreatic cysts, headaches, and we're talking about tumor and tumor-like lesions. Would this be transverse or longitudinal myelitis? I'm going to show you that. Most likely not. ADM could be. Could this be a spinal cord neoplasm? Of course it could be. If you put all the small pieces of the puzzle together, MS, most likely not. Hydromyelin, no. This was a spinal cord neoplasm. Or that's what we thought. So we called the patient into our hospital, we did imaging, and what do we see? We see multiple, strongly contrast-enhancing nodules with a lot of edema, vasogenic edema, maybe also some venous edema, and you see a lot of small vessels next to it. You see those vessels? Over here and over there. So what is your most likely diagnosis now? Tuberous sclerosis, I'm not going to show it 2 times. Sturge-Weber-Dimitri syndrome, no. Von Hippel-Lindau, wait a second. Von Hippel-Lindau, don't they have cystadenomas of the epididymis and pancreatic cysts? And they can have which kind of tumors? So most likely it's von Hippel-Lindau syndrome. And the tumor which you were seeing, of course, was hemangioblastoma in von Hippel-Lindau syndrome, which can be multifocal along the spinal cord, multifocal in the posterior fossa. About 1 to 7% of those spinal cord neoplasias belong to this group. Can be intramedullary, can extend to the inter and extradural space, may hemorrhage inside the spinal cord or also within the subarachnoid space, slowly growing, maybe solitary and multiple von Hippel-Lindau. Also that first dog, gentleman, pretty girl, pretty dog, that was also an hemangioblastoma, and all those vessels were because of the hypervascularized tumor. So what other kind of tumor-like lesion should you consider? There's so many: infection, hemorrhage, tumor-effective demyelination, phacomatoses, treatment-related issues, and metabolic disorders. Look at a couple of cases, and this is a case from Kling Chong from London, from Great Ormond Street Hospital. And he showed this case to me. You see here a big mass lesion in the thalamus and T1 peripherally hyperintense. Tumor or tumor-like? This is another patient from the same family. Multiple focal contrast-enhancing nodules in the basal cistern. Both children had a tuberculous meningitis, and the first one was a big solitary tuberculoma, and this child has multiple tuberculomas. You see also radioclival abscess. So think about tuberculosis. We all thought we defeated it, but unfortunately it is back, and you should always think about it as a differential diagnosis of a focal mass lesion. Now, this was one of the first cases I had to show during the neurosurgery conference when I started working at Johns Hopkins, being very nervous at this big institution, and this was a follow-up imaging of a butterfly glioma. And as represented, now they didn't tell me follow-up butterfly glioma, they just said this is a follow-up imaging, what do you think? And I saw this in oncology conference, most likely it's a tumor, but I don't see the tumor. I see something T1 hyperintense, a little bit of enhancement periphery. I see dilated Jacob-Robin spaces, some hemosiderin, and a lot of edema. I don't see really markedly restricted diffusion. And I brought up, could this be something else than a butterfly glioma? I brought up, could this be something like a spontaneous hematoma, maybe sitting within the spleen of the corpus callosum, maybe related to an AV malformation? Now, on follow-up imaging, it disappeared. And there's more follow-up imaging, it completely disappeared. Only the hemosiderin deposits were residually seen later on. And it wasn't a small AV malformation which had ruptured apparently. However, they did a lot of interventions to rule out the tumor. They had done, and I'm not showing it for the angio, of course it was an angio, but they had done 2 brain biopsies, etc., and they had upset the parents and the children and themselves most likely. So always think about what else it could be. It's not always a tumor. And if you see a big mass lesion and you're confused, accept it that you can be confused and look for answers. You see here an ill-defined T1 hypo, somewhat peripherally enhancing, T2 cortical hyperintense lesion. Here's some dark pixel artifacts on diffusion-weighted imaging. It has some mass effect, not that much for the extent of the lesion. What is your most likely diagnosis? Cavernous angioma, cavernous hemangioma. Of course, this is a nonsense. There are no hemangiomas in the brain. We saw they can be close to the central nervous system this morning. Oligodendroid gliomas, they can be somewhat hyper, they don't have to enhance significantly. Venous infarction, arterial infarction. Why I'm putting that in there? Now, if you look carefully, here is the thrombus in the superior sagittal sinus, and that is the contralateral lesion. This is a superior sagittal sinus thrombosis, and this is an ongoing venous ischemia with venous edema within the cortex. And I just put this differential next to it. This is a patient who has an oligodendroid glioma confirmed, and also here you see it can look rather similar. Always check all the imaging findings and do not jump on the most obvious imaging finding. This is a straightforward one. Of course, you have to put it in a tumor-like lesions. It's almost embarrassing to show it over here. We see a cystic lesion with peripheral enhancement. We see multiple Dawson fingers. Nobody will make here the misdiagnosis. And of course, this is a tumor-effective multiple sclerosis plaque. And it is well known that depending on the size and the mass effect, they can mimic tumors. But if you look carefully, you see the other lesions, you will not make this misdiagnosis. But ADM can be a little bit confusing. If you see a child coming in with this and you have no clinical information, I think many of us will be a little bit nervous to say this is just ADAM, or acute disseminated encephalomyelitis. Now, it is big. It is contrast enhancing, it is multifocal on both sides, it has not that much of mass effect, so you should start doubting it that this is a tumor. And here the story helped us. There was a previous upper respiratory infect story, so eventually the diagnosis was made that this most likely is an acute disseminated encephalomyelitis, and follow-up imaging showed that it's progressed, or that it improved over time, and that the child did very well after 3 months. Now, the last case I want to show and share with you is, we briefly discussed at the end of the previous talk, we should be aware of what we are sometimes doing to the brain, and that it can be very confusing for us, and we cannot always make this prospective differentiation between tumor or something else. Definitely advanced imaging will help us over here. This was a child with a medulloblastoma, a confirmed medulloblastoma, typical location, posterior to the fourth ventricle, midline. Surgery was being performed. There was a so-called complete or radical surgery was being performed. Fourth ventricle is nicely here empty, no tumor visible, everything looks great. Patient nevertheless had some additional treatment, and this is the follow-up imaging, and this is rather scary. We see suddenly a significant contrast enhancement in the left middle cerebellar peduncle. It is irregular, centrally it's hypointense, a lot of edema around it. It looks ugly, and it has some mass effect, but not that much of mass effect. So here, if you are in this situation, this time point, it can be difficult to say for sure this is pseudo-tumor progression due to treatment. If you look here at the signal intensity of the skull base of the bone marrow, you know radiotherapy was being performed. And this would have been my question, which I'm not taking out here. But you see in follow-up imaging, it resolved spontaneously. So this is just this very extensive reaction which you can have based upon radiotherapy, and it can confuse you. And I always find it impressive if the oncologist said, it's okay, we expected this. In this particular situation, indeed, our oncologist said, it's no problem. We were aware of this. It was a high dose which we gave, and it will resolve, and indeed it resolved. So my question would have been here, what is it? Recurrent medulloblastoma is always something to consider. CSF seeing inflammation, necrosis, or pontine myelinolysis, and you know it is radiation necrosis. So in summary, the only thing which I think the most important key points of this 25-30 minutes lecture is always be prepared for the unexpected. It's also what makes our job, I think, always fascinating every day. Always consider non-neoplastic etiologies. Even when the story is so straightforward for a tumor, it can still be something else which is not a tumor occurring due to treatment or just bad luck. Child can have had surgery and afterwards develops an abscess. I think we should always try to take full advantage of the imaging tools which we have, use high-resolution anatomical and functional techniques. Always, always, always have a good correlation with your clinical history, findings, follow-up, and know what kind of treatment was done. And never forget this phrase, rare presentation of a common disease is more frequent than the common presentation of a rare disease.